هذا الاسبوع
صرف معلومات
لا خلص مش انه انت مصر هو راح يتوزع قيم.
ايوه
صح؟
ايوه والله مش عارف شو تعرف بصير في هيدا ناصر يترمش
نرجع اصلا الاجل سلايدات الشباب.
ايوه
شباب على الزوم يعطيكم العافيه، السلايدات واضحه قدامكم مش هيك؟ تتغير؟
سيدي الله يعطيك العافيه، بتتغير وشيرنج وامورها تمام.
ممتاز.
والله
صحتك.
medium. بلش؟ بلش؟ طيب يعطيك العافية جميعا. Today we're going to talk about morbidity and mortality cases. Yes, my case will be a morbidity case, and it's about a limping child, and it's an unusual case, and we shall all be interested in this case for our knowledge and for if you experience something like this in the future, to be open-minded about all differential diagnoses possible if you get something like this. So the case is about a 3-year-old boy who was medically free with a history of left inguinal herniorrhaphy at the age of 7 weeks, brought to the ER by his family, complaining of fever, sore throat, and left thigh pain and limping of 2 days duration. Now, the child was first seen by the pediatrician, who noted that the child was diagnosed with follicular tonsillitis few days before the ER visit and treated with oral antibiotics. اتوقع لهون typical نشوفنا زي هيك سيناريو يعني هسا what happened next that there was no response on oral antibiotics and the fever continued. Then he started limping because of left side pain. So the pediatrician referred the child to the orthopedic resident who was in the ER. Now the child was assessed, examined. So the child was assessed and examined, and laboratory and imaging studies were sent by the orthopedic residents. The findings, we start with the vitals. His temperature was 39. He had normal heart rate, blood pressure, and respiratory rate. In taking the history, the child had fever since 1 week with sore throat. Then 2 days before the ER visit, he had left thigh pain. The child had no history of trauma, no previous history of same complaint, no other sites of same complaint. So we are talking about his left lower limb. On examination, the child had left side tenderness. He had good left knee and hip range of motion. And there was no swelling, no redness, no hotness in the left lower limb. But the child refused to bear weight. So this is the X-ray for the child. What do you think? What's wrong with this X-ray? Sure. Not involving the hip joints. Hello. Other than this, lateral view. ممكن. Yes. Asa, we have a limping child, 3 years old. There is something wrong with his limb, whole limb. You can't diagnose or you can't exclude anything by just giving an X-ray or asking for X-ray for his knee or his distal femur or his proximal tibia. He is a limping child. He might have a needle in his foot and he doesn't know about it. So all the time, if you have a limping child, you all should think for the limb from the toes until the sacroiliac joint. He's limping, there's something wrong, and he's not lying. He's only 3 years old, so there is something wrong. Now, yes, this is the mistake. There's only X-ray for the knee. And the resident might, at that time, he thought that the problem with his knee. And that's why his focus was on only around this area. And we should all know that, no, he's limping. We should be thinking of any kind of problem. And we all know about, for example, the radiating pain. Hip problem might cause a knee pain. So yes, this is his X-ray. And if we look at this X-ray, I think we all know that there's nothing wrong about this X-ray. There's no fractures, no abnormal features, no foreign bodies. So he sent him for knee ultrasound. And the knee ultrasound showed minimal amount of joint effusion, but not significant comparing to the other side. His white BCs was 10,000. His ESR was 87, and his CRP was positive. Was weakened, and we don't have CRP with titer, but it was positive. So he advised the pediatrician to admit the child and to be followed up. Now the pediatrician labeled the child as a case of follicular tonsillitis with transient synovitis. Here, I think that the pediatrician was thinking of reactive osteoarthritis because he admitted the child and gave him IV antibiotics because his diagnosis was follicular tonsillitis, not responding to oral antibiotics. So he gave him IV antibiotics. Transient synovitis mostly comes with viral infection. So if you are thinking about bacterial infection and you give him IV antibiotics, you are thinking about reactive osteoarthritis. So also they sent for him ASO, which was negative, Procella test, and also it was negative, and rheumatoid factor, it was negative. 4 days after the admission, they consulted us about the case. And we saw the patient at the ward. He was still febrile, 39. His temperature did not subside all the 4 days. The child is still complaining of left thigh pain. He had no redness, no swelling, and on examination, he had relatively good left hip and knee range of motion. There was no guarding. He did not block any movement on the hip or knee. And lower than knee, he had no problem at all. So our problem started to be focused on the proximal femur or in the femur, because there's something wrong with this child. His white BCs was 9.7, his ESR 92. So we ordered a pelvic X-ray and an MRI. Now, this is the X-ray for the child. Is there anything wrong, do you think? Do you see something wrong with him, with this X-ray? Well, we are thinking about left side. Now, when you first look at the X-ray, you think, no, mostly there's no abnormalities. طبعا لأنه الصورة هاي مأخوذة من تليفون فشوي في غباء في كل مكان. But there's something wrong here in the lateral cortex of the proximal femur. You might think this might be a view-wise, but when we saw the MRI, we got what we are thinking about. So here is the MRI. This is an axial view, T2. And we see here in the proximal femur and the soft tissue surrounding it, there is enhancement. There is hyperintensity. Okay, thank you. Here on the left side, there is enhancement in the proximal femur and the soft tissue surrounding. And you think, yes, there's some sort of inflammatory process. This might be osteomyelitis, right? Also, there's abnormal geographical appearance lesion in the proximal femur. It's the same, this is the sagittal view, is the same as this coronal view is the same as the axial view in the slide before. But the problem is that it's not only here in the proximal femur. Also, there's a problem in the acetabulum, left acetabulum, and also there is a problem in the left iliac wing and on the right iliac wing. So, here and here and here, geographical abnormal appearance here on the left wing, left iliac wing. Also, there was on the right, but in other views. Now, we looked at the report for the MRI. It showed left-sided mild hip effusion, and it was not significant. We contacted them. The child had bone marrow edema in both iliac wings and left-sided proximal femur with surrounding fat planes enhancing. There is multifocal geographical shape hypointense lesion seen in both iliac wings, in the left acetabulum and in left proximal femur shaft. These features could represent multifocal osteomyelitis with bone infarcts, and correlation with clinical picture and lab result is advised. However, other differential diagnostic possibilities cannot be ruled out. Now, when you look at the report and the MRI, and you see the MRI by yourself, there's something wrong with this child, and the report was not conclusive that this is osteomyelitis. And as we all know, when we have an osteomyelitis, it's mostly represented with single bone. It rarely, you can see it in multiple bones at the same time. And like this, in hematogenous spread, what we were thinking about, there's something wrong. But in correlation with his clinical picture, that the child had follicular tonsillitis before, he's febrile, he's high, he has high SR, and his CRP is positive. So our impression that, okay, this is mostly, or it could be osteomyelitis, and we should start treating osteomyelitis. So we started vancomycin, we added it to the rocephin. And we didn't stop there. We discussed the case and reviewed the images with the radiologist to see why it looks like this, why there is bony infarcts, and it is acute problem, why there is bony infarct, and why there is multi-bone involved in this pathology. And they said that there is an acute process on top of chronic process happening, and that we should dig more in the history of the child, and we should ask more if there's any problem before. And we already did this, and no, his history was acute. Only started 10 days ago. Before that, the child was normal. He has healthy, active, there was no other problems with him. Also, at the same time, we consulted our seniors, specialists and consultants to see their opinion, if they encountered like this presentation, and if this could be a primary bone tumor. And no, the response no, that this is not the features of primary bone tumor. So we not excluded for sure, but we focused about osteomyelitis. And we searched also about if there is anything written in the papers about this. And we found multiple papers or case reports about acute bilateral symmetrical pyogenic osteomyelitis in children. And about, for example, this paper says between 1990 and 2003, there was reported 8 cases of acute bilateral symmetrical pyogenic osteomyelitis. Abnormal, but it might happen. Also, this case about a child, 5 years old, healthy, and he had acute bilateral osteomyelitis. And we hear notes in this report that osteomyelitis is rarely seen in more than one bone at the same time. When it does appear simultaneously in 2 or more bones, it is usually accompanied by a chronic illness, such as sickle cell anemia, for example. And we thought, okay, the child, he might have sickle cell. And we sent for him a blood film. And we contacted the pediatric team, and we told them that this child still has something else. And our focus was to treat the osteomyelitis that was going on. That is mostly, or it could be osteomyelitis. Now, 5 days after the administration of vancomycin with rocephin, clinically the child still not improving. He's still febrile. His ESR still rising. CRP is positive. He became leukopenic. His white BC is 3.6. His blood culture, which was sent at the time of admission, was negative. Now, we contacted the pediatricians and we told them, yeah, we should look, you and us, for other possibilities and other causes for this problem. They sent blood film, they sent echo, they sent chest x-ray, all to rule out causes for his high temperature. Now, on the next day, the child started complaining of right side proximal thigh pain and hip pain. And his pain on the left side increased. So our thought was, if this could be osteomyelitis on the first MRI, and the child started to complaining of severe pain, and now he's not able to move any joint in the hip joint bilaterally. So we thought, okay, he might now start to have any collection, either subperiosteal correction or effusion in the hip joint. So the MRI after 1 week showed that the child has a new geographical shaped lesions in the right-sided acetabulum. So in the left side, it increased, and now he had on the right side. And in the report said you should keep possibility of multifocal osteomyelitis. Now the patient is getting worse, and multiple discussions with the pediatrician that the diagnosis of osteomyelitis started to be the least on the list. If you have a child with if you have anyone with osteomyelitis and you started him on antibiotics and you covered we give him good antibiotics that covered most of the bacterial causes, he should at least few days after that to start feeling better, start getting better clinical wise. But even there, if there was a collection, he might have a slight bit of getting better, not getting worse. Now, this is why we thought, no, now osteomyelitis is not the cause, and there's something wrong with this child. So the pediatrician, they insisted there is no medical cause for these symptoms for them. And they contacted their consultants here. And they had the same response, that this is your problem. He had osteomyelitis, and you should treat osteomyelitis. And the bony infarcts you see, yes, you might deal with them later, but now treat his acute illness. And we try to explain to them that if it is osteomyelitis, the child should get better, but no, he's not getting better. So they refused to transfer the child in the pediatric team care in Queen Rania Hospital. Now, we consulted again our seniors here, and Dr. Malik advised me to discuss the case directly with Dr. Jamil Shawaki and to see his opinion about the subject. So I reviewed the images with Dr. Jamil, and his impression was, as is, this could be multifocal osteomyelitis, yes, but not typical features. So also it could be a bony metastatic tumor. And his advice was to do chest, abdomen, and pelvic CT to rule out any primary pathology. And if it was free, a biopsy and culture to be done. And our biopsy and culture, this was our plan before going to Dr. Jamil, because we have now got to an end. Now got on the wall where we are going with this child now. He's not improving. We are giving him everything. So we should take a biopsy and culture and to see what's going on with him. So immediately we did the images for him, and this is what we found. This is the liver. And this is a huge mass, just at the level of the liver on the left side. And this mass was large suprarenal mass, measuring 7 by 7 by 6 centimeters, and mostly represent neuroblastoma or Wilms tumor. So the child, we contacted, of course, the pediatricians, and we told them that we did what you should have done in the first place. They did not check the child properly. They did not investigate properly. They only saw word in the MRI report that this could be osteomyelitis, and their focus was on it. And we, as orthopedic surgeons, we started treating the child as osteomyelitis. It was unusual, but we said, okay, let's start treating him. If it is osteomyelitis, it's getting better, but he was not getting better, but they did not get the picture that, no, this is not osteomyelitis. So finally, yes, he was transferred to Queen Rania Hospital, and where bone marrow biopsy showed hypercellular bone marrow infiltrated by small round blue cell tumor consistent with metastatic neuroblastoma. And the child started on chemotherapy. Now that was bad news for the child, for his family, but this is life. And thank you. Any questions? على دكتور. CT للهب بوني وايز انه كأز لا look for يس هسا يس بيريوس رياكشن، واحنا كان ديسكشن مع الراديولوجيست، هم اصلا اول ريبورت كتبوه هم كانوا مش عارفين، استشاروا حتى الدكتور جميل عليه اول ريبورت، كانوا بيحكوا ابنورمال فيتشر. حكينا لهم هذول ممكن تكون this is sequestrum البليكروم، this is periosal reaction في collection sub-periosal collection. no ضلوا انه مصرين this is not a collection, this is bony infarcts, no collection you can see here. وحكينا انه هل في داعي انه نصور other views CT للهبه؟ no because this is not a collection. هم ضلوا يحكوا انه bony infarcts abnormal geographical appearance but this is not a collection. So no, we did not do a CT scan for the pelvis or the femur.
إذا كان عندي فضول أعرف شو كان من أول provisional diagnosis شافون
الامرجنسي يس مزبوط. هنا كان يعني ممكن تكون ميستيك من الريزدنت.
لا مش
انه رياكتيف ارثرايتس يس، انه limping child as اليوجوال سيناريو، انه limping child كان في عنده follicular tonsillitis، اجى limping فخلص فحصوا ما في الهب، ما في فيوجن بالني، مع انه يعني كان الفوكس على الني، يعني حتى الهب ما فكروا انه كمان صح. for no admission to be followed. بس yes this is most reactive osteoarthritis. والادميشن تبع الاطفال كان عشان follicular tonsillitis انه not responding للاورال antibiotics، فيعني كان easily could be missed the child. القصه انه يعني لما يجيك limping child you should dig وما تاخذه انه يا for granted this is mostly reactive osteoarthritis، حتى لو كان في عنده history ل follicular tonsillitis. اوكي هذا التشايلد ما طلع اوستومايلايتس، ما طلع عنده septic joint، بس still he was critically ill, he was febrile. ESR على بالطوارئ كان 90، CRP كان بوزيتيف، وتشايلد looks ill، انت خلص تشحط بريك. الاطفال مش راضيين يدخلوه مش مشكله، احنا بنبلش فيه، بس ما ضيعه، ما يروح الطفل. هسه الطفل كان ممكن ببساطه لو طبيب الاطفال بالطوارئ حكى انه مش مشكله follicular tonsillitis limping، العظام حكى لي انه ما في عنده septic joint، شكله reactive osteoarthritis، كان تروح. بس اكيد كان راح يرجع later، بس why يعني this is a mistake يعني. بس والاطفال كان احنا مشكلتنا كانت الرئيسيه كان الاطفال بعد ما نقلنا الطفل لما طلع بالريبورت الاولاني انه this is yes might be osteomyelitis، واحنا حكينا اوكي خلاص احنا هسه بنعالج نكمل العلاج ونشوف شو القصه. احنا نقلنا الطفل لاسرتنا، هون كانت بجوز احنا كان مستيك منا، يعني احنا كانت بجود ويل انه احنا بدنا ناخذ الطفل ونبلش فيه. انه الاطفال لما بعد كم من يوم لما not responding للانتيبيوتكس انه مش راضيين يقتنعوا انه يا جماعه في something wrong with this child، يعني osteomyelitis كان المفروض يتحسن، في شيء غلط، في abnormal features، مش هيك الفيتشرز بالعاده osteomyelitis، بس اقتنعوا تعالوا خلينا مع بعض ندور على كوز. بس هم شبه رفعوا ضغط. بالاخر يعني لما طلعنا احنا وصلنا لدياجنوسيس، احنا اللي ركضنا وعملنا وسوينا، وصلنا لدياجنوسيس وخلص يعني حطيناه بوجههم انه خذوا حكينا لكم من الاول في عنده الولد شيء رونج، ايوه عنده شيء رونج. بالاخر طبعا ضلوا ساكتين وخلص يعني استسلموا يعني لانه osteomyelitis ما في acute osteomyelitis، ما في collection، ما في subperosal collection، ما في collection inside the bone. not responding لantibiotics كان few days، بس still انت عامل يعني عملنا MRI ما في collection. يعني انا بدي افكر بسيرجري، اوكي في عندي بالبروكسيمال فيمر، في عندي bilateral iliac wings، في عندي left acetabulum، انا وين افتح؟ يعني ليش؟ يعني انا عندي acute osteomyelitis بس ما في collection. طب انا سيرجري تو دو وات؟ فتحت على بروكسيمال فيمر، ايش بدي اشيل؟ ما في كولكشن، في نيكروتيك تيشيو، في بوني انفاركت، بس في شيء ابنورمال. بس انا ليش بدي افتح واعمل ديبرايدمنت لشو؟ طب ماشي انا عملت البروكسيمال فيمر، هسه الاستابلوم البايلاترال ايلياك وينز شو هدول شو بدي اعمل فيهم؟ وصلت؟ فهو انت اكيوت اوستومايلايتس بتعالجه اي بي انتي بايوتكس ما دام ما في كولكشن. فهو هيك كان البلان. هو دخل يوم خميس، يوم ثلاثاء تصور MRI، دخل للاطفال يوم خميس. كان هو دخل يوم خميس، يوم ثلاثاء صور اول MRI، الاسبوع اللي بعده حكيت معه. كان حكيت لي بالاخر انه دكتور مالك قال لي خلص، يعني اذا قبل ما نشوف دكتور جميل واتناقش معه، خلص كان البلان انه ناخذ كلتشر بايوبسي، خلص يعني نفتح وناخذ كلتشر بايوبسي.
Okay, thank you, Dr. Ahmed, for this nice presentation.
You're welcome.
Really, it was an unusual presentation for limping child. We usually have a limping child. We usually have it as reactive synovitis, septic arthritis, or osteomyelitis. But now this bony pathology led us to a hidden tumor inside the abdomen, Wilms tumor. So this was our morbidity case.
كانوا
مصرين osteomyelitis.
فاحنا تقبلنا المريض بكل صبر ورحمه، فهي الله يعطيكم العافيه. انتم صرتوا لديكم يعني فخر انتم صرتوا، الله يشافي المريض، بس يعني مع الاسف يعني الاطفال ما كانوا متعاونين، يعني بعد تعالوا يبحث في نقش وعنده يعني اتيبيكال يعني ما حدا فكر فيها منهم، بالعكس هذا انجازي.
الله يعافيك.
واحنا دائما الصدقه رحب، اي حد ما بده يدخل المريض يدخل، ما عندنا مشكله. والله انت ما قصرت صراحه.
Okay, now okay, we are done with the morbidity case. Now we will shift to another type of cases that we have some malmanagement, maltreatment, and we'll be discussing a mortality case, a case which we dealt with in our rehabilitation center here. Let's have a look about this case and have a discussion on it. We'll have this case presentation with Dr. Abdel.
Okay. Thank you, Dr. Ahmed, for your presentation. Our presentation now will be about the mortality case. This case was being managed in Real Rehabilitation Center. Okay. And we will focus on the medical legal issues in this case, not the ecopemur per se. 86-year-old female patient, previously healthy, presented to ER after non-symptomal falling down from standing position with left hip pain and inability to bear weight of 2 days prior to presentation. Okay, the patient previously walking without assistance. Okay, physical examination, general appearance, patient conscious, alert, oriented, stable vital in the ER. Chest exam, good air entry, no crackles, no wheeze. Abdomen was soft and lax, no abdominal tenderness. Lower limb examination, the patient has shortened, external rotated, local tenderness at the left groin area and painful range of motion, and bowel distal pulse. Okay, this X-ray show left side subtrochanteric fracture. Okay. Investigation was done in the ER was CBC. The patient has low BCV. Kidney function test was within normal range. ECG and chest X-ray has been done. Bilateral Doppler ultrasound done, no evidence of DVT. Okay, and medical evaluation done بالER. As the admission order كان يعني من المقيمين إنه complete bed rest, good pain management, ribanin, Promal, anticoagulant prophylactic dose, gastric protection medication like Pomodar, and IV fluid resuscitation. As after 2 days before surgery, at the night shift, the patient become agitated and suddenly change in level of consciousness. So the orthopedic resident was called by the nursing team. The patient was febrile, 38 Celsius, hypotense, and desatting. So, and he did some investigation. CBC, the patient has leukocytosis. So the resident called the internal medicine doctor on call, and he consulted him regarding this case and his impression, the top of the list of differential, PE, acute insult brain hemorrhage, or septic shock. So he ordered a brain CT, septic workup, and the CT angio to rule out PE. And he couldn't give the patient anticoagulant therapy due to the high risk of hemorrhagic CVA. So, and he ordered the chest CT angio, but we couldn't proceed with the imaging due to the patient clinically is unstable. Okay, after that, and the next morning, the CPR team was called, and the patient, and they tried to resuscitate the patient, but the patient was dying. Okay, and this is the point from this mortality case. After that, Royal Medical Service opened investigation regarding the cause of the death, opened the reviewing the patient record on the Hakim, no orthopedic follow-up noted was documented on Hakim. So they blame the orthopedic team, هم يعني بالأخير المقصرين, although they did almost what can be done because not written, not done in the medicine. Okay, and thank you.
Okay, thank you, Abdul Hadi. Our message from this presentation that although we are doing very high efforts both in the ER, but it is a must to document what we are doing. We asked and we requested for a medical consult. The medicine or the medical team, they gave us a consult and they gave an order. But we didn't write our impression, we didn't write our plan, what we are going to do. So finally, if there's any investigation and there is anything to be asked about, they return back to the records. And then we found that there's no notes written by our team, nothing documented. So all in all, Alex, do you have any comments?
الريسوسيتيشن احد الاقاويل المقيم ترك الريسوسيتيشن وراح على شغله ضروريه شوفها يعني دخلنا حالنا بمتاهات احنا بغنى عنها زي ما حكى الشباب ناصر وعبد. We did almost everything للمريض وانا ما كنت يعني ما وقفت مع المقيمين المناوبين لحد الان بس لو نقعد مع بعض احنا مقصرين لانه ما كتبنا شيء تبطل. انا ما بستنى من سيستر تيجي تشهد لي والله اجى ناصر الشرح وشاف المريض. انا شهادتي تشهد لي اني انا اجيت وايموت اروح. هذا حكي مش بس للمريض هاي. لو تيجي تلف راوند الجمعه السبت احد بغض النظر اي لحظه المريض ممكن تكون لابس يصير عليه مشكله، دوكيومنت انه انت اجيت بهي اللحظه ولفيت على المريض وكتبت تحمي حالك بالسطرين هذول. لا تكتبوا بدون ما تشوفوا المريض. احد النوتات يا اخوان لاحد المقيمين عندنا هون الله يسهل عليهم، مريض اردني كان بالصدفه عامل عمليه ونايم عندنا بالفرح لعدم وجود سبب بالحسين، تم كتابه نوت او قبلت نوت من مقيم. ليش؟ لأن المقيم بقعد باخذ ليسته المرضى دوينج فاين دوينج فاين، لاحظت الأخطاء. شفت مريض بكتب على طول اي دوكيومنت. احنا هذا الهدف بدنا نتعلم. مقيم باطني مشكور كان عند جدة استشرناه، هذا لا يعفينا من انه نكتب اوفيشال ميديكال كونسلتيشن. الجونيور يستشير السينيور، السينيور معه اخصائي، الاخصائي يستشير الاخصائي الاول. فهي مشان نحمي بعضنا. انا معكم بس هي بدنا نتعلم. نقلت المنظمه الوردانيه على الجروب، اضاف لنا مدير خدمات طبيه على الجروب رؤساء دوائر الاختصاصات واحنا المعنيين فيها. نقلت النبذه زي ما حطيتوا فيها على الجروب الثانيه. فهي مشان تحموا حالكم، اذا صار اي شيء لا سمح الله، واحنا ان شاء الله ما بصير شيء، بس احنا حالنا صار اي شيء امام الله اذا بالشهاده انه شفنا المريض. انتوا نفس الشيء يعني لو بتجربوها ان شاء الله ما بتجربوها مع اهلكم يعني بتحبوا المريض الواحد يمر على اهالينا يقول لهم كلمتين نور يسلم على المريض. طبيعي المريض بالبصر اهله بالبصر تفضل اهل المتوفى اجوا شاكرين لي. حكيت للمدير وللجنه المنظمه انه الشباب يعني الاهل اجوا قالوا الله يخلف عليكم الله يرحمهم وانتم ما قصرتوا. بس بالنهايه مدانين احنا بنظر الخدمات الطبيه مقصرين لانه ما كتبنا. انتم موست اوف ذا في نقاط هيك خفيفه بس يعني لا تؤثر. فنترجاكم المره الجايه هالكلمتين اكتبوا لابكم كتبوها لكل مريض. لو تلبسوا جمعه وسنه اكتبوا، الايام العاديه اكتبوا. لا تسمحوا لابن، لا تسمحوا لاي واحد يناقشكم ليش يا دكتور ليش يا مقيم استاذ. موتي ولا يتنادى طبيب عظام يا اخوان قدام المدير او قدام مدير الخدمات. كاني انا بالدائره والله لو ضربك اصغر مقيم عندنا في الدائره قدام مسؤول يتحاكم او ينبه كاني انا. فلا تخلوني دائما اشعر بهذا الشعور. كلكم اخوان صغار انا اكبركم من الدائره عمرا فلا تخلوني بهذا الموقف. وكل انتم وبش كلكم اخوان. فاللي كاتب كلمتين اكون اب يا اخوان مش راح تغير عليهم. المناوبه اللي بتشعروا فيها انه في ضغط هي الشيء موجود في الشيء بيساعد. هي انا كلام مسؤول عنه هي زيتون واللي بعد زيتون. المناوبه اللي بتحسوا حالكم مضغوطين غير مع زيتون، زيتون مضغوطين جبلنا. بس لا تمشوا المناوبه بدون ما تطلبوا الاب يا اخوان. استشيروا الشباب اللي بالطوارئ بيجيك مريض لا تفتنوا. كلنا بنتعلم. انا بسال في بعض اختصاصات بحكي مع المستشارين الثانيين كلنا بنتعلم. بنموت واحنا بنتعلم. لا تفتوا احموا حالكم احنا معكم راس الهرم معي انا ومع رائد وجوه احكوا باي وقت. رائد وجوه منصوب انه علي 24 ساعه من الطوارئ من اي محل انا مستعد اجاوب. اقول تلفوني ما اروح. لا تتحمل المسؤوليه لها. اذا ما كنت متاكد من المريض بالقسم بالعمليات بالطوارئ متاكد 100% احكي مع التشيف تبعك، احكي مع الاخصائي. التشيف تبعك ما ردش عليه احكي مع اللي اكبر منه تتصل لي. وما اتوقع عمرها تتصل لعندي مشاكل لان كلكم ما شاء الله اخوان وزملاء. واحنا معكم السينيور زي الاخصائي معكم والمستشارين معكم. وان شاء الله ما واحد يضيق. بس هالشويه التعليمات التزموا فيها وان شاء الله انه تمشوا بكره على خير ان شاء الله وتشعروا بالفرق التعامل المره الجايه بيننا وبينكم ان شاء الله. الله يعطيكم الجميع العافيه.
الله يعافيك سيدي. ثانك يو سير. شباب اي حدا عنده اي سؤال اي استفسار عن حالتين سواء الموربيديتي كيس الاولى او المورتاليتي كيس حكيناها الان. اوكي يعطيكم العافيه. كل الشكر سيدي يعطيكم العافيه.